Imagine a child going to sleep perfectly healthy, right? But they wake up with their face so swollen that their eyes are like practically forced shut.
Right, the classic morning puffiness.
Exactly. And, this isn't some acute allergic reaction or a localized infection. The root cause is actually buried deep in their lower back, where this microscopic filter it's silently unzipped.
Yeah, the structural failure is profound.
Right. Or take another patient. They walk into the clinic, their blood pressure is spiking dangerously near stroke levels, and they're producing urine the color of dark cola.
Which is terrifying for a parent to see, obviously.
Oh, absolutely. And all of that chaos, it's just because of a simple skin infection they had and completely recovered from like 3 weeks ago.
Yeah, we're really looking at the butterfly effect of cellular failure here.
Totally.
If you're sitting with a patient's chart or, trying to unpack the clinical protocols for massive renal failure, the diagnostic landscape can feel completely paradoxical.
What do you mean?
Well, you have these massive outward systemic crises, right? But they're driven by damage so localized and minuscule that it often completely evades standard light microscopy. So today we are diving into nephrotic syndrome and acute glomerulonephritis.
Yeah, and we are putting the textbook aside for this deep dive. We're treating you like a colleague right here in the room with us.
Exactly. You already know the terminology.
Right, you know the basics, but we need to unravel the mechanistic why behind these presentations. We're looking at these clinical entities not just as boring lists of symptoms to memorize, but as two distinct narratives of microscopic plumbing gone wrong.
I love that analogy. And to ground this, we really must visualize the glomerulus itself first.
Okay, set the scene for us.
So it operates fundamentally as a barrier, right? Based on size and charge. It prevents systemic macromolecules from spilling into the urinary space while still allowing plasma water and small solids to pass freely.
So think of it as a highly sophisticated, multi-layered coffee filter.
Yes, exactly.
A perfectly working filter lets the water through to make the coffee, but it keeps all the grounds, the essential cellular components and large proteins trapped in the blood where they actually belong.
Right. And nephrotic syndrome, our first narrative today, that's when the filter's mesh breaks down or gets entirely too wide.
The grounds just start pouring into the cup.
Yeah, the structural integrity of that barrier is compromised. The essential macromolecules the body relies on for, well, fundamental homeostatic balance, they're just passively lost.
Just leaking out.
Exactly. But our other narrative, acute glomerulonephritis, is a completely different mechanism. The filter isn't necessarily widening, it's actually being choked by the debris of an immune system crossfire.
Oh, wow. So the pressure behind the filter climbs exponentially because the channels are literally physically blocked by inflammatory infiltration.
Spot on. It's a structural unzipping versus an inflammatory chokehold.
Okay, I like that distinction. A structural unzipping versus an inflammatory chokehold. Let's start by looking at that structural unzipping in nephrotic syndrome.
Good place to start.
If we're examining the clinical presentation, we're looking for a highly specific 4-stage domino effect, right?
Yes, the 4 classic pillars. You cannot diagnose the clinical entity without these. And the primary trigger, the absolute first domino to fall, is massive proteinuria.
Massive. And what is the actual clinical threshold for massive here?
It's firmly established in the protocols. We are looking for urine protein excretion exceeding 40 milligrams per square meter per hour.
Okay, 40 milligrams per square meter per hour.
Right, or if you're doing a full 24-hour collection, it's greater than 50 to 100 milligrams per kilogram.
But waiting 24 hours isn't always practical, right?
Exactly. For rapid clinical decision-making, we use a spot urinary protein creatinine ratio. You do this on the first early morning urine, and if it exceeds 2.0, that provides the diagnostic confirmation of that massive leak.
So the physical barrier is failing, and the protein is just dumping into the urinary space.
Right.
And that direct, unmitigated loss leads instantly to the second domino, which is severe hypoproteinemia.
Because it's all going down the drain, literally. The serum protein plummets below 25 grams per liter.
Below 25 grams per liter. And the dominant casualty here, the specific macromolecule being drained in the highest volume, is albumin, right?
Yes, albumin is the main player, and albumin is the primary driver of plasma oncotic pressure.
The magnetic pull keeping the water in the blood vessel.
That's got it.
Yeah.
So with that circulating albumin gone, the third and most visible domino falls, generalized edema.
The swelling.
Exactly. But then there's the fourth domino, which often seems paradoxical at first glance, and that's hyperlipidemia.
Yeah, characterized by serum cholesterol levels shooting past 250 milligrams per deciliter, right?
Correct, over 250.
Okay, I want to pause on that fourth domino because the first three, they're simple mechanics.
Yeah.
You lose the protein through the filter, the blood becomes depleted of protein, and without the protein to hold the water shifts into the tissues. Simple. But if the primary failure is a leaky renal filter, we need to map out the exact pathway that forces the cholesterol to suddenly spike.
Yeah, it's a great question. The hyperlipidemia is actually entirely a hepatic overcompensation.
The liver is reacting to the kidneys problem.
Exactly. The liver functions as the body's primary manufacturing hub. Right. When the serum albumin drops so precipitously, the liver's sensors detect that profound hypoproteinemia.
And the subsequent drop in plasma oncotic pressure.
Right. So it interprets this as a critical systemic deficit of structural building blocks. It thinks the body is starving for protein.
So the liver throws the entire assembly line into overdrive to replace the lost albumin.
It does. But, and here's the catch, the hepatic synthesis pathways are not perfectly isolated. In its frantic, kind of uncalibrated effort to mass-produce albumin and other plasma proteins, the liver inadvertently upregulates the synthesis of lipoproteins as well.
Oh, I see. It's indiscriminately pushing everything out of the factory doors.
Exactly. It's not just making albumin. It's making everything, including all these lipids.
So we have an overproduction issue. But if the liver's just making too much, surely the body's natural lipid clearance mechanisms would try to ramp up to handle the excess load, right?
Well, under normal circumstances, yes, they would. But nephrotic syndrome delivers a dual hit to the lipid balance.
A dual hit?
Yeah. At the exact moment the liver is overproducing these lipoproteins, the body's ability to clear them is actually severely compromised.
Wait, why is the clearance compromised?
There's a marked decrease in lipid catabolism because the plasma levels of lipoprotein lipase, which is the primary enzyme responsible for breaking down circulating triglycerides, those enzyme levels actually drop.
Because it's a protein and it's getting peed out.
Partly, yes, and there are other complex regulatory mechanisms, but the end result is a massive deficit in clearance.
Wow. So the factory is flooding the market with product and the waste disposal infrastructure has simultaneously collapsed.
That's a perfect way to put it. The hyperlipidemia is inescapable at that point.
Okay, that makes perfect sense now. Now, if we return to the third domino, the massive generalized edema, we have to look closer at the actual pathophysiology of the fluid shift.
Right, the swelling.
We know the oncotic pressure drops because the albumin is gone, but let's look at the microscopic structural failure that let the albumin escape in the first place.
Yeah, we have to zoom way in. The primary structural failure occurs at the level of the podocytes.
The podocytes.
Right. These are highly specialized epithelial cells that reside on the visceral side of the bone's capsule. They're fascinating cells. They have these long primary processes that branch into secondary foot processes.
Like tentacles.
Exactly like tentacles.
Okay.
And these foot processes interdigitate, wrapping intricately around the glomerular capillaries.
So they form the final physical mesh. The spaces between those interdigitating tentacles are the filtration slits.
Yes, and those slits are bridged by a crucial zipper-like protein structure called the slit diaphragm.
The zipper.
Right. In nephrotic syndrome, the fundamental pathology is the destruction or effacement of those foot processes.
So the intricate tentacles lose their structure and just kind of fuse together.
Exactly. They fuse, completely disrupting the slit diaphragm. The functional permeability of the glomerular capillary wall just drastically increases.
The zipper breaks. And the albumin, which normally carries a negative charge that helps repel it from the similarly charged filtration barrier, it just slips right through the compromised mesh.
It slips right through into the urine, and once the albumin is in the urine, the circulating plasma oncotic pressure is absolutely decimated.
Which throws the Starling forces completely out of whack.
Completely. The Starling forces, which govern fluid movement across capillary membranes, are destroyed. The hydrostatic pressure pushing fluid out of the vessels remains relatively constant, but that magnetic pull of the oncotic pressure holding the fluid in, it's just gone.
So the fluid follows the path of least resistance, leaking directly out of the circulatory system and saturating the interstitium.
Yes, which leads to a critical secondary cascade. This is where it gets really dangerous. Because the fluid is pooling in the tissue spaces, the actual intravascular volume, the functional circulatory volume contracts significantly.
Right. The pipes are running dry while the walls are flooding.
I love that. Yes, the pipes are dry. And the body's baroreceptors located in the carotid sinus and the aortic arch, they register this severe drop in effective circulating volume.
They think the patient is bleeding out.
Exactly. The macula densa in the kidney also senses the decreased sodium delivery. The body perceives a state of massive dehydration or hemorrhage, even though the total body water is actually profoundly elevated.
So the thermostat is completely misreading the room.
Exactly. The physiological response to perceived hypovolemia is the immediate aggressive activation of the renin-angiotensin-aldosterone system, the RAAS pathway.
Ah, okay. Let me see if I remember this cascade. The juxtaglomerular cells release renin, which converts circulating angiotensinogen to angiotensin I. And then the ACE enzyme converts that to angiotensin II, which is a potent vasoconstrictor, and that then stimulates the adrenal cortex to release massive amounts of aldosterone.
Perfect. Secondary hyperaldosteronism. The aldosterone acts on the distal convoluted tubules and collecting ducts, basically screaming at them to reabsorb every possible molecule of sodium.
Because wherever the sodium goes, the water strictly follows.
Exactly. The body is desperately trying to refill that dry intravascular space.
But, and here's the tragic part, the primary defect, the unzipped slit diaphragm, it hasn't been repaired.
Nope. Still broken.
So the newly retained sodium in water, they simply dilute the remaining albumin even further, dropping the oncotic pressure even lower, and the new fluid immediately leaks right back out into the interstitium.
It creates a brutal, self-perpetuating cycle of accelerating edema. It just gets worse and worse.
It's mechanical quicksand.
Yeah.
So, okay, we understand the cellular failure and the systemic cascade it triggers. The obvious diagnostic question becomes, who is this happening to, and what initiated the podocyte effacement?
Right. What broke the zipper?
Exactly. If we look at the demographics and causes, we see a massive divergence in the data.
We do. The classification breaks down into primary or idiopathic causes and secondary causes. Globally, the vast majority, roughly 90%, are primary.
Meaning the pathology originates intrinsically within the kidney architecture without, like, an identifiable systemic trigger.
Exactly. And when we look at the histology of these primary cases, the variant that absolutely dominates the landscape, making up about 85% of idiopathic presentations, is minimal change lesion.
Minimal change lesion, and the nomenclature here highlights a fascinating diagnostic hurdle, doesn't it?
Oh, it really does. If you take a renal biopsy of a patient with minimal change lesion and examine it under standard light microscopy or even employ immunofluorescence, the glomerular architecture appears entirely unremarkable.
It looks normal.
Totally normal. You might observe a slight, almost negligible increase in mesangial cells, but the structural integrity appears completely intact.
But the patient is exhibiting massive ascites, profound proteinuria, and a totally unhinged RAAS pathway. Yet the standard biopsy reveals nothing.
Nothing. You have to magnify the tissue under an electron microscope to actually see the pathology. Only at that extreme resolution does the widespread effacement and fusion of the podocyte foot processes become visible.
So the cellular architecture has literally melted, but it requires electron microscopy to confirm it.
Exactly. And the clinical relevance of identifying minimal change lesion is paramount because the prognosis and treatment trajectory are highly specific here. Over 95% of these cases demonstrate a profound positive response to corticosteroid therapy.
Oh, wow. 95%, that's highly responsive.
Very responsive, which sharply contrasts with the next primary histological variant, focal and segmental glomerulosclerosis, or FSGS.
FSGS, and that accounts for about 10% of idiopathic cases, right?
Yeah, it's roughly 10%.
And FSGS implies a physical scarring, not just a fusion of the processes like minimal change.
Right. The sclerosis is focal, meaning it affects some glomeruli, but not all, and it is segmental, affecting only portions of the individual capillary tufts. The podocyte injury here is severe enough to cause actual detachment from the underlying basement membrane.
Which leads to the accumulation of extracellular matrix, right? The scar tissue.
Exactly. And because there is physical scarring and tissue death, the response to steroids is dismal. Only around 20% achieve any meaningful remission with steroids or cytotoxic agents.
Wow, that's a huge drop from 95%.
It is. The trajectory frequently heads relentlessly toward end-stage renal failure for those patients.
Okay, so that's minimal change at 85%, FSGS at 10%. What about the remaining 5%?
The remaining 5% of idiopathic cases present as diffuse mesangial proliferation. Under light microscopy, you actually observe a marked diffuse increase in both the mesangial cellularity and the surrounding matrix.
And how do they respond to therapy?
The therapeutic response sits somewhere in the middle, with roughly half of the patients responding to steroids.
Okay, so that covers the idiopathic landscape, which really dominates the temperate regions. In those climates, the onset is typically early, with a peak incidence between 2 and 5 years of age.
Right, very young children usually.
But the clinical picture fractures when we shift geographically, right?
It changes dramatically. In tropical regions, the epidemiology shifts. The age of onset moves slightly later, typically between 5 and 7 years.
Okay.
But more critically, the primary idiopathic etiology is eclipsed by secondary causes.
So the post-site effacement is not an isolated event.
Right, it is collateral damage driven by an underlying systemic pathogen or disease process.
And the array of secondary culprits is extensive, but the protocols specifically highlight that parasitic infections are particularly brutal on the renal architecture.
Extremely brittle. The classic example in endemic regions of West and East Africa is Quartan malarial nephropathy.
Plasmodium malaria.
Yes, Plasmodium malariae is notorious for this. The chronic circulating presence of the malarial antigens provokes a sustained immune response. The resulting immune complexes eventually deposit within the glomerular capillary walls, inciting a localized inflammatory response that damages the filtration barrier and unzips the podocytes.
Leading directly into the nephrotic cascade.
Exactly. We also see similar immune-mediated damage from hepatosplenic schistosomiasis, which is heavily documented in regions like Egypt.
Right, and filarial infections like Loa Loa or onchocerciasis.
Yeah, the microscopic worms, or their metabolic byproducts, create circulating immune complexes that the kidneys simply cannot clear without sustaining massive structural damage.
But the infectious triggers extend well beyond parasites, too.
Oh, absolutely. Congenital syphilis, hepatitis B and C, and HIV are profound drivers of secondary nephrotic syndrome.
I read that HIV-associated nephropathy often presents with a rapidly collapsing form of FSGS that is highly resistant to therapy.
It is. It's very aggressive. Then we have the systemic, autoimmune, and metabolic culprits. Systemic lupus erythematosus frequently manifests with severe renal involvement.
Henoch-Schönlein purpura as well, right?
Yes. Diabetes mellitus leading to diabetic nephropathy, amyloid deposition physically choking the glomerulus, or even cardiovascular events like a sudden renal vein thrombosis severely altering the hemodynamics.
The list is huge. And we also have to consider nephrotoxins, right?
You must meticulously rule them out. Heavy metals like mercury directly poison the tubular and glomerular cells. Pharmacological agents, particularly penicillamine, have documented nephrotoxic profiles.
And what about genetic causes, like sickle cell disease and Alport syndrome? They fundamentally alter the microvasculature and basement membrane integrity, right?
They do. And if the underlying cause is genetic, it fundamentally alters the timeline we discussed earlier. We aren't just looking at toddlers or school-aged children anymore.
Right. If the genetic blueprint for the slit diaphragm is flawed from conception, the filter is leaking in utero.
Exactly. That manifests as congenital nephrotic syndrome, which by definition presents within the first 3 months of life.
Okay, so under 3 months is congenital.
Right. If the presentation delays slightly, presenting between 4 and 12 months, it is classified as infantile nephrotic syndrome.
And the genetics behind the congenital form are incredibly specific. The mutations directly target the structural proteins we were just discussing, the zipper.
They do. We see mutations in the NPHS1 gene, which encodes for nephrin, the core transmembrane protein of the slit diaphragm. Without functional nephrin, the zipper simply cannot form.
It's just a completely open channel.
Exactly. We also see mutations in NPHS2, which affect podocin, another vital structural protein that anchors nephrin to the podocyte cytoskeleton. We also look for mutations in the WT1 gene, the Wilms tumor suppressor gene, which is critical for early renal development.
Now, what if the congenital presentation isn't driven by inherited genetic mutations? What else causes it that early?
The secondary suspects there are the in utero infections, collectively grouped under the TORCHES acronym.
Torches. Let's break that down. Toxoplasmosis, other agents, specifically syphilis rubella, cytomegalovirus, and herpes simplex.
Exactly. If a fetus is exposed to CMV or rubella during critical windows of organogenesis, the viral replication actively disrupts nephrogenesis. The glomerular basement membrane forms improperly, and the infant is born with a profoundly incompetent filtration barrier.
So we have mapped the structural failure, the systemic cascade, and the etiology. Now, we need to step into the clinic.
Let's do it.
We need to construct the physical and laboratory profile of a patient actively undergoing this massive fluid shift.
Well, the presenting complaint is almost universally the edema, but its progression is highly methodical, dictated entirely by tissue compliance and gravity.
Tissue compliance. So the periorbital tissue, the area around the eyes, has extremely low compliance, making it highly susceptible to early fluid accumulation.
Exactly, the classic morning puffiness. During sleep, the patient is supine, allowing the fluid to pool evenly in the loose facial tissues.
But as the patient assumes an upright posture throughout the day, the hydrostatic pressure shifts.
Right. Gravity exerts its pull on the extravasated fluid, drawing it downward through the tissue planes. So the facial edema visibly wanes, migrating sequentially to the perineum, the sacrum, and eventually pooling as massive pedal edema in the lower extremities.
And when the extravascular fluid volume becomes so massive that the tissue planes can no longer contain it, it breaches the peritoneal cavity.
Yes, resulting in massive ascites.
Fluid in the abdomen.
The physical examination must meticulously assess this fluid distribution. You have to demonstrate a fluid thrill across the abdomen, or confirm shifting dullness upon percussion as the patient changes position.
To solidify the presence of free-flowing intra-abdominal fluid rather than, say, an organomegaly or a solid mass.
Exactly. And systemically, the patient will likely present with profound anorexia, abdominal pain potentially caused by the sheer physical stretching of the hepatic capsule or the mesentery, and an altered bowel habit, often diarrhea.
Diarrhea? Why diarrhea?
Because the edematous bowel wall fails to absorb nutrients and water properly, the gut itself is swollen.
Oh, wow, the gut is swollen too. That makes sense. Now, what about the vital signs? We discussed the RAAS cascade attempting to correct the contracted intravascular volume.
Clinically, this manifests as marked oliguria, urine output dropping below 1 milliliter per kilogram per hour. The kidneys are violently retaining sodium and water.
Right, but the blood pressure reading is the critical differentiator here, isn't it?
It is the absolute key. Despite the massive retention of sodium and water, despite the total body fluid overload, hypertension is remarkably uncommon in uncomplicated nephrotic syndrome.
Which feels completely counterintuitive.
It does. But you have to remember, the fluid refuses to remain within the vascular compartment. The oncotic pressure is completely inadequate.
So the actual hydrostatic pressure against the arterial walls, the blood pressure remains normal, or even drops into hypotensive ranges, predisposing the patient to hypovolemic shock.
Exactly. The fluid is in the pipes, it's in the walls.
So the physical exam points heavily to the unzipped filter. Let's move to the laboratory investigations to get absolute confirmation.
The urinalysis is the immediate frontline tool. A simple dipstick will violently react, showing 3+++ or greater for protein.
3 pluses. And moving to the microscopic examination of the urine sediment, we are looking for the downstream evidence of the hyperlipidemia.
We find hyaline casts, which are simply coagulated Tam-Horsfall proteins taking the shape of the tubules. But the hallmark finding is the presence of oval fat bodies.
Oval fat bodies. These are the visual confirmation of the lipiduria, right?
Yes. The liver is overproducing lipoproteins. They spill through the damaged glomerulus, and as they travel through the nephron, the renal tubular epithelial cells attempt to reabsorb them.
And trying to save the fats.
But the tubular cells become so engorged with these reabsorbed lipid droplets that they completely lose their structural integrity. They detach from the basement membrane and slough off into the urinary space.
And the protocols state that under polarized light microscopy, these oval fat bodies display a highly characteristic Maltese cross appearance.
They do. It's very distinct.
To quantify the leak definitively, we rely on the spot urine protein creatinine ratio exceeding 2.0. But the sources also highlight the utility of a urine protein selectivity index.
Yes, the selectivity index analyzes the molecular weight of the proteins being lost.
How does that help with the diagnosis?
Well, a highly selective proteinuria means only lower molecular weight proteins like albumin are escaping. This suggests a milder disruption, typically minimal change lesion, which heavily predicts a robust response to steroid therapy.
Okay, and a non-selective proteinuria.
That's where massive immunoglobulins are also spilling out, suggesting severe architectural destruction like FSGS, which predicts a poor response.
Makes sense. Now, the blood work mirrors the urinary losses. Serum albumin is critically depressed below 25 grams per liter, and the lipid panel is severely elevated.
We also analyze the electrolytes, urea, and creatinine to monitor the baseline renal function. Interestingly, that often remains relatively preserved in the early stages.
Because the actual glomerular filtration rate hasn't collapsed, the filter is just leaking.
Precisely. But the immunological blood profile is where we establish our most critical differential marker. We evaluate the serum complement levels, specifically C3.
Okay, this is vital. In the context of nephrotic syndrome, the C3 levels return completely normal.
Normal. The normal C3 indicates that the complement cascade, the body's aggressive, protein-based immune response, is not being actively consumed or weaponized against the kidney in this specific pathology.
Right. The failure is structural, not an active immune complex consumption.
Exactly.
We need to hold on to that normal C3 finding because it becomes the pivot point when we discuss our second narrative later.
Yes, plant a flag there. The remaining investigations in this phase focus entirely on ruling out the secondary etiologies we discussed.
So what are we running?
You must run an ASO titer to exclude recent streptococcal activity, a full blood count, and a peripheral smear to hunt for malaria parasites, anti-DNA antibodies, and ANA profiles to rule out lupus.
Retroviral screening for HIV.
Hemoglobin electrophoresis to identify underlying sickle cell trait or disease, fasting blood glucose for diabetes, hepatitis B and C serologies, and depending on the endemicity, stool microscopy for schistosoma ova.
Okay, so let's say we have confirmed the diagnosis of primary idiopathic nephrotic syndrome. We have a patient with massive ascites, a critically low intravascular volume, and kidneys that are spilling albumin uncontrollably. We must intervene.
We must. And the management requires a highly orchestrated, multi-tiered protocol.
Starting with the immediate supportive phase.
Yes. The focus is on meticulous fluid and dietary management. The absolute cessation of added dietary salt is non-negotiable.
No added salt.
Zero. The body is already maximizing its sodium reabsorption via the RAIS pathway. Introducing exogenous sodium will only exponentially worsen the tissue pooling.
Right. The diet should provide adequate caloric intake and high biological value protein, though aggressively pushing protein in the diet doesn't necessarily reverse the hypoproteinemia as fast as the kidneys are losing it, right?
That's true. You can't just eat your way out of it. But the fluid restriction is a mathematically precise calculation.
Walk us through that calculation.
If the patient presents with massive incapacitating edema, the fluid input is restricted exclusively to replacing insensible losses.
And insensible loss is strictly calculated at 400 milliliters per square meter of body surface area per 24 hours.
Exactly. That covers the obligatory fluid loss through respiration and dermal evaporation. You give them nothing more.
What if the presentation is a bit less critical?
Then the formula adjusts to matching the previous day's documented urine output, plus that calculated insensible loss. We balance the ledger exactly, refusing to give the tissues any excess fluid to hoard.
But, dietary and fluid restrictions are really slow interventions. If the ascites is compromising respiratory excursion, or if pulmonary edema threatens respiratory failure, we require aggressive pharmacological diuresis.
We do. We deploy loop diuretics, primarily furosemide.
The dosing parameters here are pretty aggressive, aren't they?
Vary. 1 to 2 milligrams per kilogram per dose, administered intravenously. In severe refractory cases, that dosing frequency can escalate to 4 to 6 times daily.
Wow. And furosemide operates by directly inhibiting the NAK2Cl symporter in the thick ascending limb of the loop of Henle, right?
Yes, forcibly preventing the reabsorption of sodium and, consequently, water. We might also layer on oral hydrochlorothiazide to block the distal convoluted tubule, or spironolactone, at 3 to 5 milligrams per kilogram per day.
To directly antagonize those massive aldosterone levels.
Exactly.
But wait, we encounter a massive pharmacological contradiction here, don't we?
The volume paradox, yes.
Right. We are deploying potent diuretics to force the kidneys to excrete volume. But the patient's actual intravascular volume is already critically depleted. The fluid is all in the tissues.
Right.
If we aggressively diurese a severely hypovolemic patient, don't we risk plunging them directly into hypovolemic shock or triggering acute renal failure by completely starving the kidneys of perfusion?
We absolutely do. That's why the intervention must respect the oncotic physics. Before we can safely force the fluid out of the body, we must pull the fluid out of the tissues and back into the vascular compartment.
Ah, okay. So how do we do that?
If the oncotic pressure is dangerously low, we precede the furosemide with an intravenous infusion of 25% salt-poor human albumin.
We synthetically restore the magnetic pull.
Exactly. We infuse usually 1 gram per kilogram over several hours. The concentrated albumin rapidly expands the plasma volume, pulling the interstitial fluid back across the capillary membranes.
So once the vascular compartment is refilled and the renal perfusion is stabilized, then we administer the furosemide to flush the newly mobilized volume out through the urinary tract.
It is a precise mechanical maneuver to resolve the acute, life-threatening swelling.
But it offers no structural repair to the podocytes themselves.
None at all. To achieve actual remission, to zip the filter back up, we rely almost entirely on prolonged corticosteroid therapy.
The heavy artillery. Prednisolone is the foundation of this protocol.
The dosing is massive, and the duration is grueling. We initiate at 2 milligrams per kilogram per day, or 60 milligrams per square meter, capping at a maximum daily dose of 60 milligrams.
Why cap at 60?
Because beyond 60 milligrams, the immunosuppressive and metabolic toxicities outweigh any additional benefit to the podocytes.
Okay, so up to 60 milligrams, and this is administered orally as a single daily dose every single day for an initial phase of 4 to 6 weeks.
Right. Glucocorticoids like prednisolone operate on multiple cellular levels. They cross the cell membrane, bind to intracellular glucocorticoid receptors, and translocate into the nucleus where they directly alter gene transcription.
They profoundly suppress the synthesis of inflammatory cytokines.
Yes, and there's mounting evidence that they also directly stabilize the podocyte's actin cytoskeleton, essentially forcing the foot processes to rebuild their structure.
Okay, so after that initial 4 to 6 week daily barrage, the protocol shifts to an alternate day regimen.
The dose steps down to 1.5 milligrams per kilogram per day, administered every other morning for an additional 8 to 20 weeks.
So we are looking at an absolute minimum of 12 weeks of intense immunosuppression.
At least. And because the physiological toll of this regimen is so high, we must rigorously classify the patient's response using highly specific clinical definitions, relying heavily on the daily early morning urine dipstick.
Right. The optimal outcome is remission, which is strictly defined as the complete absence of protein on the urine dipstick or mere trace amounts for 3 consecutive days.
The filter is holding.
The filter holds. Conversely, a relapse is documented when a patient who previously achieved remission presents with 1+ or greater proteinuria on the dipstick for 3 consecutive days, accompanied by the clinical return of edema.
And if the underlying pathology is aggressive, the patient might fall into the frequent relapse category. That's defined as experiencing 2 or more relapses within a 6-month window, or 3 or more within a single year.
What if the steroids just don't work at all?
That's the most challenging categorization. Steroid resistance is defined as the persistent failure to achieve remission, despite 6 to 8 continuous weeks of adequate daily maximum dose steroid therapy.
The podocytes simply refuse to respond to the glucocorticoid signaling.
Right, and then there's steroid dependence. This occurs when a patient successfully achieves remission on the high-dose therapy, but predictably relapses almost immediately upon attempting to taper the dose or upon complete cessation.
The structural integrity relies entirely on the continuous presence of the drug.
Exactly. In cases of frequent relapse, profound steroid toxicity, or absolute steroid resistance, we must pivot to alternative, often more aggressive, immunosuppressive, or cytotoxic agents.
So we escalate to alkylating agents, primarily cyclophosphamide. The regimen there is typically 2 to 3 milligrams per kilogram per day, administered for an 8 to 12-week course.
Right. Cyclophosphamide functions by cross-linking DNA strands, profoundly inhibiting the proliferation of B and T lymphocytes, fundamentally altering the immune system's interaction with the podocytes.
Chlorambucil is another alkylating option utilized in specific protocols.
We also leverage calcineurin inhibitors, predominantly cyclosporin A and tacrolimus. These agents block the calcineurin pathway in T cells, preventing the transcription of interleukin-2, which is vital for T cell activation.
In steroid-resistant cases, tacrolimus is frequently administered in conjunction with low-dose alternate-day steroids to force a remission.
It's an intense pharmacological gauntlet. And while we navigate it, we must aggressively monitor for the profound complications intrinsic to the nephrotic state itself.
Right, because the structural failure of the glomerulus doesn't discriminate. It loses albumin, but it also indiscriminately dumps other critical plasma proteins.
Exactly. The patient is in a severely hypercoagulable state. The risk of massive spontaneous thrombosis is incredibly high.
Why are they so hypercoagulable?
It's multifactorial. First, the leaky filter dumps massive amounts of antithrombin III, which is the body's primary endogenous anticoagulant.
They're peeing out their blood thinners.
Yes. Simultaneously, the liver's uncalibrated overproduction of proteins results in skyrocketing levels of fibrinogen and other procoagulant factors.
So more clotting factors, fewer anti-clotting factors.
Plus, the severe intravascular volume depletion causes profound hemoconcentration, increasing blood viscosity.
The blood is thick, sluggish, and completely stripped of its natural clot-busting proteins.
It's a recipe for disaster. This precipitates deep vein thrombosis in the lower extremities, cerebral venous sinus thrombosis, and critically, renal vein thrombosis, which can acutely choke off the kidney's remaining perfusion.
Wow. And the infection risk is equally devastating, right?
Oh, massively. The glomerulus is leaking massive quantities of immunoglobulin G, IgG, and factor B, a critical component of the alternative complement pathway.
The immune system's primary circulating weapons are literally being flushed down the toilet.
The patients are exquisitely vulnerable to encapsulated bacteria like Streptococcus pneumonia. We frequently see episodes of primary peritonitis where that massive pool of ascites fluid in the abdomen becomes acutely infected, presenting a severe systemic emergency.
And the hypovolemia itself presents a constant threat of advancing to shock, and the diminished renal perfusion can ultimately precipitate acute renal failure.
The clinical journey is precarious, but the long-term prognosis hinges heavily on the initial histological presentation.
Right. If the biopsy confirmed minimal change lesion, the vast majority, while potentially navigating relapses, eventually outgrow the condition with preserved renal architecture.
But if the pathology reveals focal segmental glomerulosclerosis, or if the etiology is linked to aggressive secondary agents like Cortan malaria, the prognosis darkens significantly. The scarring progresses, the hypertension becomes intractable, and the trajectory steadily arcs toward chronic kidney disease and the eventual need for renal replacement therapy.
Okay, that concludes the narrative of the unzipped, structurally compromised filter. We now shift our focus to the second major mechanism of renal failure. The passive massive leak is replaced by an explosive, violent immune confrontation.
We step into the pathology of acute glomerulonephritis.
AGN, let's break it down.
Acute glomerulonephritis, or AGN, is defined fundamentally as a diffuse inflammatory condition targeting the glomeruli of both kidneys simultaneously. Crucially, the architectural damage is not a spontaneous structural failure.
Like it was in nephrotic syndrome.
Right. It is almost entirely secondary to a severe immunologic mechanism.
So the clinical presentation abruptly shifts from the nephrotic pattern to the classic acute nephritic syndrome. The protocols define the syndrome by 5 rigid pillars, presenting a stark contrast to everything we just analyzed.
Yes, the 5 pillars of the acute nephritic syndrome are 1. Profound oliguria, 2. Gross hematuria, meaning visibly bloody urine, 3. Edema, 4. Severe hypertension, and 5. Rapidly advancing renal insufficiency.
Okay, so let's highlight that contrast. Nephrotic was massive protein and normal blood pressure. Nephritic is massive blood and spiking blood pressure.
Exactly. And to decipher this divergence, we must analyze the histology under the microscope.
Let's do it. What does light microscopy show us for AGN?
Well, returning to light microscopy, the biopsy of an AGN patient looks like an active battlefield. The glomeruli are physically massively enlarged. We observe a violent diffuse proliferation of the intrinsic mesangial and endothelial cells.
And the capillary lumens.
They are completely choked by the massive infiltration of circulating inflammatory cells, particularly polymorphonuclear leukocytes.
The immune system's heavy infantry has literally invaded the filtration space.
In the most severe iterations, the cellular proliferation breaches the Bowman space, forming distinct crescent shapes that physically crush the capillary tuft.
Wow. And if we shift to immunofluorescence microscopy, what does that reveal about the weaponry involved?
It reveals what pathologists term fine, lumpy, bumpy deposits scattered diffusely along the glomerular basement membrane and within the mesangial areas.
Lumpy, bumpy deposits. I love that term. Those are the literal remnants of the immune crossfire.
They are. They are dense accumulations of immunoglobulin G, IgG, and complement proteins, specifically C3, plastered against the filtration barrier.
And when we maximize the magnification using electron microscopy, those deposits appear as dense, discrete, subepithelial humps resting on the outside of the basement membrane, right beneath the podocyte foot processes.
Right. To understand how humps formed, we must trace the entire pathophysiology of the immune cascade. AGN is fundamentally an immune complex disease.
Okay, let's trace it. It initiates far away from the kidney, usually as a localized infection.
Yes. The invading pathogen introduces foreign antigens into the bloodstream. The body's humoral immune system mounts a defense, synthesizing massive quantities of highly specific IgG antibodies designed to neutralize those precise antigens.
So the antibodies locate the circulating antigens and bind to them, creating massive interlocking antigen-antibody complexes, or AGAB complexes.
Exactly. And because the kidneys receive roughly 20% of the total cardiac output, these massive circulating immune complexes are inevitably swept right into the renal microvasculature.
And they're too big to pass through.
They're physically too large to pass through the filtration slits. They crash into the glomerular basement membrane and become tightly lodged, physically trapping themselves within the delicate mesh.
But the deposition is only the primer, isn't it?
It is. Once lodged within the glomerulus, the FVC portion of these aggregated antibodies acts as a massive beacon, violently activating the systemic complement cascade.
Ah. And the activation occurs via both the classical pathway driven directly by the immune complexes and the alternative pathway.
Right. The complement cascade operates like a biological explosive charge. As the proteins cleave and activate sequentially, they consume massive quantities of circulating C3.
And the cleaved complement fragments, particularly C5a, serve as incredibly potent chemotactic agents. They broadcast an overwhelming chemical signal that aggressively recruits circulating neutrophils and macrophages directly into the glomerulus.
So the arriving inflammatory cells unleash a barrage of proteolytic enzymes, reactive oxygen species, and inflammatory cytokines directly onto the trapped immune complexes, completely disregarding the innocent glomerular tissue caught in the crossfire.
Friendly fire.
Massive friendly fire. The resulting inflammation physically swells the capillary walls and chokes off the lumen. The filter isn't just leaking, it is being strangled.
Okay, so the etiology driving this massive formation of immune complexes, it's heavily dominated by one specific bacterial family, right? Group A, beta hemolytic streptococcus.
Yes, but not just any generic strep infection. These are highly specific nephritogenic strains. These strains possess specific cell wall antigens like the M protein that are structurally prone to forming these kidney-destroying complexes.
The epidemiology tracks these specific strains meticulously. Serotype 12 is the dominant nephritogenic strain responsible for AGN following acute pharyngitis or strep throat.
And serotype 49 is the primary culprit following streptococcal skin infections, commonly referred to as pyoderma or impetigo.
And the geographical divide we noted in nephrotic syndrome dictates which of these strains a patient is most likely to encounter, right?
Exactly. In temperate zones, post-streptococcal AGN is overwhelmingly a sequela of pharyngitis. It presents predominantly in children between 4 and 10 years of age, and fascinatingly, it exhibits a distinct gender disparity, affecting males twice as often as females.
But in tropical climates, the etiology shifts. The pharyngeal cases drop, and AGN becomes heavily secondary to the pyoderma strains, very frequently arising as a complication of infected scabies lesions.
Right. The demographic profile shifts younger, and the male-to-female ratio equalizes at 1.1.
Now, here's the most critical diagnostic clue in the patient's history: the timeline. The profound renal failure does not coincide with the acute fever and sore throat.
No, it doesn't. There is a mandatory silent latent period.
Because it takes time to manufacture the weapons.
Precisely. Following a streptococcal pharyngitis infection, the latent period typically stretches for 2 to 3 weeks.
The immune system requires that window to undergo B-cell clonal expansion, synthesize the specific IgG antibodies, allow the AgAb complexes to aggregate in the plasma, and finally deposit them in sufficient quantities within the glomerulus.
Right, it takes weeks to trigger that massive complement activation and subsequent inflammatory chokehold. And if the inciting event was a cutaneous pyoderma infection, the latent period is noticeably extended, sometimes stretching up to 6 weeks before the renal cascade initiates.
Wow, 6 weeks. So the patient totally forgot they even had a skin infection.
Exactly. They think they're perfectly fine. Now, while group A strep is the overwhelming majority, the clinical history must also interrogate other potential infectious triggers.
Like what else?
Staphylococcal bacteremia, severe pneumococcal infections, or viral agents like Coxsackie B, echovirus type 9, and hepatitis B can all theoretically generate the necessary immune complexes. Fungal and rickettsial infections are also documented, albeit rare, triggers.
Okay, so the latent period ends when the inflammatory chokehold reaches critical mass. The clinical presentation of the patient walking into the clinic is dramatic, generally divided into an initial severe oliguric phase, followed by a resolving diuretic phase.
The onset is marked by profound, nonspecific systemic malaise, high fever, and lethargy. The patient frequently complains of a deep, dull flank pain.
And that flank pain is the direct result of the violently inflamed, enlarged renal parenchyma physically stretching the highly innervated renal capsule, right?
Yes, the kidneys are physically swollen. Edema is present, but it differs mechanically from the nephrotic presentation. It is generally less massive and less gravity dependent.
But the defining critical vital sign is the blood pressure. These patients present with severe, often life-threatening hypertension.
The hypertension is a direct hemodynamic consequence of the choked glomeruli. The inflammatory infiltrate drastically reduces the actual glomerular filtration rate. The macula densa senses a massive drop in sodium delivery, and the juxtaglomerular apparatus perceives profound renal ischemia.
So the kidney assumes the entire body is bleeding out, and it triggers a massive RAAS cascade.
Right, but unlike nephrotic syndrome, where the retained fluid immediately leaked into the tissues because of low albumin, the AGN patient's liver is fine. Their albumin levels are relatively intact.
Ah, so the oncotic pressure holds.
Exactly. The oncotic pressure holds. Therefore, the massive volume of sodium and water being violently retained by the aldosterone is trapped entirely within the vascular compartment.
The intravascular volume expands exponentially, driving the hydrostatic pressure against the arterial walls to dangerous hypertensive extremes.
That's the mechanism. And the second defining hallmark is the urine itself, the gross hematuria. The urine is classically described as coke-colored or resembling smoky tea.
Why is it that color?
The inflammatory damage to the glomerular basement membrane is so profound that the structural integrity is breached. Circulating red blood cells are physically forced through the jagged, inflamed tears in the filtration barrier.
And as they are squeezed through these microscopic breaches, they become dysmorphic and heavily damaged.
Exactly. So the clinical picture is stark. But to finalize the diagnosis, we must run the laboratory investigations. If we place the lab results of an AGN patient next to a nephrotic patient, the contrast provides a masterclass in differential diagnosis.
Let's do that rapid-fire comparison. The urinalysis microscopy is definitive. In nephrotic syndrome, we saw oval fat bodies from hyperlipidemia. In
In AGN, we see red cell casts.
red cell casts. As those damaged red blood cells bleed into the tubular lumen, they become trapped within a matrix of TAM-horsefall protein. They coagulate into perfect microscopic molds of the renal tubules.
And the presence of a red cell cast in the urine is absolute undeniable proof that the bleeding is originating directly from a ruptured glomerulus, not from a lower urinary tract source like a bladder infection.
Right. What about the dipstick protein analysis?
It diverges too. While AGN patients exhibit some proteinuria due to the membrane damage, it typically registers at only 1+ or 2+ seripos, starkly contrasting the massive 3+++ or greater dumping seen in nephrotic syndrome.
And the comprehensive metabolic panel.
It reflects the choked filtration. During the oliguric phase, the blood urea, nitrogen, and serum creatinine climb rapidly. Because the tubules cannot excrete potassium, dangerous hyperkalemia develops.
And the inability to excrete acid load results in a measurable metabolic acidosis, reflected by low serum bicarbonate.
Correct. The complete blood count will reveal anemia, but the specific morphology is critical. It is a normocytic, normochromic anemia.
Meaning the bone marrow is producing perfectly healthy, normal-sized red blood cells with adequate hemoglobin. So why are they anemic?
The anemia is entirely delusional. Because the vascular compartment is massively overloaded with retained fluid, the concentration of red blood cells is artificially watered down.
Wow, that's fascinating. But the definitive immunological marker, the pivot point we established earlier, is the serum complement level. In nephrotic syndrome, C3 was completely normal. In acute glomerulonephritis,
The serum C3 level is profoundly depressed.
low C3, the diagnostic proof of the mechanism. The massive trapped AGAB complexes acting as a beacon consumed nearly all the circulating C3 to fuel the localized inflammatory explosion in the kidney. The tank is simply empty.
Exactly. And to completely lock the diagnosis, we run targeted serological tests to definitively prove the streptococcal origin. We measure the ASO titer anti-streptolysin O, which is highly elevated following pharyngeal infections.
And for post-pyodermal presentations,
The anti-DNase B titer is often a more reliable marker of recent streptococcal activity.
the protocols also mention the strep design test, a highly sensitive slide agglutination procedure that rapidly detects a broad array of antibodies against streptococcal extracellular products, including streptolysin O, hyaluronidase, and streptokinase.
So the diagnosis is locked. We are managing an explosive, post-infectious inflammatory cascade. The critical difference in management compared to nephrotic syndrome is that the immune reaction has already peaked. We do not require months of massive toxic steroid suppression.
The weapons have already been fired. The treatment protocol is entirely supportive. We must meticulously manage the massive collateral damage, the volume overload, and the spiking pressure while we wait for the immune system's phagocytes to quietly clear the debris and unchoke the filter.
Yes, the foundation of management is strict bed rest, particularly vital during the acute oliguric phase, when the risks of cardiac failure and severe hypertension are at their peak.
Meticulous hourly fluid input and output charting is mandatory to monitor the fluid retention and anticipate volume overload crises.
Dietary management restricts salt to prevent further volume expansion, restricts potassium to mitigate the life-threatening hyperkalemia, and restricts protein slightly to reduce the urea burden on the failing filtration rate.
And to accelerate the resolution of the volume overload, we utilize diuretics again, right?
We do. Furosemide is administered intravenously at 1 to 2 milligrams per kilogram per dose. By forcing the loop of Henle to dump sodium, we break the cycle of intravascular volume expansion.
And we also address the original spark. Even though the inciting streptococcal infection likely cleared weeks ago, we must ensure absolute eradication of the organism to prevent any further antigen release.
So a 7 to 10-day course of oral penicillin V or erythromycin for allergic patients is standard protocol.
But the immediate minute-by-minute priority for the clinical team is the aggressive management of the hypertension, isn't it?
It has to be. If the pressure isn't controlled, the downstream vascular complications become rapidly fatal.
So we deploy potent antihypertensive agents. Hydralazine is a primary choice, dosed at 2.5 milligrams per kilogram per day. It acts as a direct vasodilator, relaxing the smooth muscle and the arterioles to drop the peripheral resistance.
We also use methyldopa, a centrally acting alpha-2 adrenergic agonist, utilized at 10 to 40 milligrams per kilogram per day. We also frequently employ ACE inhibitors like captopril.
If we use captopril, we are directly attacking the secondary mechanism. We are inhibiting the angiotensin-converting enzyme, effectively snapping the RAS chain and preventing the formation of angiotensin II, which stops the massive vasoconstriction and halts the aldosterone-driven sodium retention.
But what happens if the blood pressure aggressively breaches the autoregulatory limits despite these oral interventions?
We face the most terrifying complication of AGN, hypertensive encephalopathy.
Yes, the cerebral vasculature possesses an intrinsic autoregulatory mechanism that constricts or dilates to maintain constant blood flow to the brain regardless of systemic blood pressure. But in malignant hypertension, the systemic pressure physically overpowers the constriction of the cerebral arterioles.
So the high-pressure fluid is violently forced across the blood-brain barrier right into the cerebral tissue.
Exactly. The resulting cerebral edema manifests as agonizing headaches, visual disturbances, severe vomiting, and profound alterations in consciousness.
The pressure physically crushes the brain tissue against the skull, frequently triggering massive, intractable seizures.
Management of hypertensive encephalopathy requires immediate emergency intravenous intervention. We utilize rapid-acting IV vasodilators like diazoxide or continuous IV hydralazine infusions to aggressively but carefully bring the pressure down.
And the accompanying seizures are acutely managed with intravenous diazepam or intramuscular paraldehyde.
Beyond the neurological catastrophes, the severe intravascular volume overload places immense strain on the myocardium, frequently precipitating acute congestive cardiac failure, requiring aggressive diuresis and potentially inotropic support.
And if the inflammatory chokehold is too severe, the oliguria progresses to absolute anuria, locking the patient into acute renal failure.
But despite all of this, despite the seemingly insurmountable violence of the acute presentation, the natural history of acute glomerulonephritis is overwhelmingly favorable.
Really? After all that?
Yes, the clinical course follows a highly predictable trajectory towards spontaneous resolution.
The timeline of recovery is incredibly rapid once the corner is turned. With precise supportive care, the diuretic phase initiates. The massive fluid overload and edema typically resolve completely within 5 to 10 days.
And the terrifying hypertensive spikes normalize within approximately 2 weeks as the intravascular volume normalizes.
The gross hematuria, the terrifying coke-colored urine, usually clears within 1 to 2 weeks, though microscopic hematuria may persist for months as the basement membrane slowly heals.
The ultimate prognosis is exceptional. Complete recovery occurs in greater than 95% of cases.
That's incredible. The structural damage heals, the filtration rate returns to baseline, and unlike the grueling, relapsing nature of nephrotic syndrome, recurrences of post-streptococcal AGN are exceedingly rare.
The immune system generates lasting, specific immunity against that specific nephritogenic strain. The mortality risk is almost entirely confined to the acute phase and is almost always preventable through meticulous management of the hypertensive and hyperkalemic crises.
The dichotomy between these two clinical entities provides profound insight into renal pathophysiology.
It really does. It is the tale of two completely divergent microscopic failures.
On one side, the structurally unzipped filter of nephrotic syndrome, a passive, devastating leak of albumin that fundamentally alters the oncotic physics of the body.
It triggers a desperate hepatic overcompensation, resulting in massive hyperlipidemia and a panicked RAAS cascade that drives massive tissue-saturating edema. It demands a grueling, months-long pharmacological siege to force the podocyte architecture to rebuild.
And contrasting that, the inflammatory chokehold of acute glomerulonephritis, an explosive, localized war zone triggered by the delayed collateral deposition of immune complexes following a seemingly minor bacterial infection.
The resulting complement-driven inflammation physically strangles the filtration, driving massive intravascular volume expansion, severe hypertension, and structural bleeding. It is a violent storm that requires intense supportive navigation until the immune system naturally clears the wreckage.
The mechanical precision and the cascading consequences are truly staggering. The realization that a localized patch of impetigo on a child's arm can silently trigger a highly specific humoral immune response that weeks later perfectly aggregates, crashes into the delicate mesh of the renal filter, and violently alters the hydrostatic pressure dynamics of the entire circulatory system. It fundamentally changes how you view systemic interconnectedness.
The interplay between the initial pathogen, the delayed immune response, and the massive unintended collateral damage leaves us with a compelling final consideration regarding the nature of chronic disease.
Oh, absolutely. If the violence of acute glomerulonephritis is essentially the immune system inadvertently crippling a vital organ because it mistook the delicate renal architecture for the clustered debris of a long-dead bacteria, how many other obscure, idiopathic, chronic conditions, sudden organ failures, or mysterious systemic inflammatory diseases are simply the quiet, unrecorded aftermath of an immune system that successfully won the initial battle, but fundamentally lost its bearing during the cleanup?
The cascade of the cure inadvertently becomes the genesis of the disease.
The friendly fire of the cleanup crew. That is a mechanism to keep you analyzing the history of every patient who walks through the door. We will leave you to deconstruct that one. Thank you for joining us for this incredibly detailed deep dive into the microscopic battlegrounds of the kidney. Until the next deep dive, keep questioning the why behind the symptoms. Stay curious, everyone.